Let's review one of my first cataract surgeries as a resident. It actually was featured on Cataract Coach's YouTube channel, and we will take a look at it in this video. What's up guys, Zach here with Dr. Eyeball MD. If you're new to the channel, I'm a third-year ophthalmology resident. So in today's video, let's go ahead and review one of my cataract surgeries, actually my 8th cataract surgery. So this was day 2 of cataract surgery for me. And I thought it was one of my better ones, so that's why I sent the video to Cataract Coach on his website, and then he posted it on his YouTube channel and reviewed it. And so let's take a look at it. And I'll tell you kind of what was going through my head in the case and that kind of stuff.
CataractCoach.com. Newbie resident cataract surgery. We're gonna watch a junior resident doing case number 8. What's good and what needs improvement?
I like how he called me newbie resident. So it's true. So first off, he sped this up to 4 times speed. So this is much slower than it actually was. So I'm going at a quarter of the speed that you're watching here. So the case was what, 6 minutes? So it was like a 24, 30-minute cataract, something like that, I guess. And he edited it, so it's probably even a little longer than that. Anyways, here we go. So we make the para.
So starting off the case with a good paracentesis there. Looks like it's gonna be a right-handed surgeon.
I am right-handed.
Trypan blue dye is being used to help increase the visualization.
We start all of our cases with trypan blue when we're first learning, just because it helps us visualize the capsule. Just to make it easier to do the rexus. So that's why I'm using it here.
Even though there was a good red reflex, sometimes putting trypan blue dye for a junior resident does help a lot.
And then just burping out a little because I felt like I put the pressure a little high, so I just kind of burped it out. And then we'll let it sit in there for like 45 seconds.
Also, there's an added benefit. Trypan blue dye makes the lens capsule a little bit less elastic, so maybe less likely to run out.
Learn that from him.
There's some anesthetic going in the eye.
It's actually not anesthetic, it's just
and now time for some viscoelastic.
Anesthetic for
we sped up the video at 4 times normal speed. So the function here when you're doing case number 8 is not speed, it's not even efficiency, it's safety.
So I didn't put in enough viscoelastic there, so I'll go back in and put more in, but one of the tips from his videos is actually to go all the way across the chamber and then kind of back it up so you don't get that spaghetti string type viscoelastic. So that's one thing I tried to do here.
And learning, making sure you're getting better every case. So this is case number 8.
So I know it's
and let's see what the main incision looks like. Here's the keratome.
So use that to stabilize.
And starting off there, fixating that with forceps.
So we try to do like a triplanar incision. So go in here, travel up through the stroma at kind of a lamellar like pass, and almost up to that line on the keratome there, and then we'll enter the chamber. We'll steepen back out to enter. So it tries to make a self-sealing wound. So that's what I'm going for, and trying to kind of nick the limbal vessels like he teaches in his videos, just to promote wound healing. I don't know if that's true, but that's what he says. So that's what I did.
A reasonable incision. I'll take that. A little bit of nicking of the limbal vessels. Now we've got a few eyelashes sticking out. That's not great. So the draping could definitely use some improvement here. We don't want.
Yeah, the draping was not easy for me. I had a really hard time with the draping. It was actually a lot harder than like a lot of the steps of the surgery. Was just draping the patient right, which is stupid, but anyways, day 2.
I have eyelashes on our surgical field. Starting with a cystotome, I'm gonna do a little bit better job of centering up the eye. That looks good. And here starts the rexus. That looks great.
So get a little flap
case
there,
number 8,
try to kind of get the rexus started
pretty good.
in the direction I want.
No, I hope the patient's received a retrobulbar block.
He has not received a retrobulbar.
Case number 8,
subtenons.
You don't need to have the patient sit through a topical case. That's just not going to be comfortable for anyone. Better off doing a retrobulbar block.
So one thing he teaches here is to kind of trace the rexus as you're going. As you're making the rexus, kind of trace it with the utratas as you pull them. So that's what I tried to do. This is the hardest step of the surgery for me.
Or subtenons block. And we have great videos of that on CataractCoach.com. The rexus looks fantastic. Great job of floating in the incision.
So that part is hard. So floating in the incision, it's so you're not distorting the wound and burping out your viscoelastic, because then you lose chamber stability and then your rexus may want to run out if you don't have enough viscoelastic in. But this turn here, right, subincisional rexus is the hardest part of the rexus for me, just because you kind of have to make that turn to go a different direction.
No distortion of the incision. That's actually quite remarkable for case number 8. So that looks great. Taking that out, looks like about a 5mm capsulectus.
It's pretty
excellent. So now some downsalt solution for some hydrodissection. So here using a specialized bent cannula under the rex's edge. There's some good fluid waves. This is pretty good. If this is case number 8,
so I did get a fluid wave.
I'm pretty impressed.
But I didn't rotate. I forgot to rotate the nucleus. I should have rotated the nucleus.
I don't know if the nucleus was rotated enough. Does it spin?
No. And then
But it looks like the surgeon's preparing the phaco probe, adjusting the sleeve tip.
Was put on wrong, so I had to fix that.
And it's important here to adjust the sleeve tip to suit your method of surgery. Now going in here,
going bevel down,
bevel up, and looks like a groove down the middle.
Now it's bevel up.
And then, as we know, this groove should be a little bit deeper in the center and a little bit shallower in the periphery. And that's a pretty good groove. Nice.
So doing divide and conquer
groove,
technique. It's just what we're taught in the beginning. So that's what I'm doing.
A little bit deeper just in the center. And let's keep watching. That looks a little bit deeper. That looks great.
I'm watching the ridges.
Now the key here is to get it just deep enough.
Waiting
you
for
don't
the
want to be so
reflex,
deep that you're risking damaging the posterior capsule.
Deep enough because those ridges
and if you're so anterior and not too shallow, then you'll have a very difficult time of splitting the nucleus. And so that looks pretty sufficient to me there. If you look down in the middle of that groove, it looks like there's
kind of
a very nice
the edges by
beginning
just
of a red
taking a little off
there.
the side so I could get the
so a little bit of a break here.
The groove a little better.
Phaco probe came out of the eye. Okay, it goes back in the eye. And then now, so I'm using a paddle on the second hand. That paddle can be sometimes more effective than a chopper.
Yeah, so we use a dry
surface area, and it's able to go
more surface area.
And separate the pieces without having a sharper, smaller tip dig into the pieces.
And then rotate it.
So divide and conquer technique here. Now splitting into quadrants.
Gotta get far enough here to get it in there.
And this surgeon has really done practice in a wet lab. This is amazing for case number 8. If this is truly a junior surgeon doing it on his or her own, this is pretty impressive. So 4-quadrant divide and conquer.
We got lucky there and got
first quadrant now is coming up out of the capsular bag. That looks great. Using the spatula in the second hand
to try to keep the
centrally.
Phaco
and you'll notice
in the center.
Phaco probe's in a good position. The eye staying in primary pretty much, and the nuclear pieces being brought up to that iris plane for emulsifying. This is great. This is a resident who has been studying cataract coach videos, not just.
He's right. I studied a lot of his videos because I was pretty nervous to do cataract surgery for the first time, and so I watched his videos and tried to learn as much as possible. Do these surgeries in your head, you know, tens if not 100 times before you go to the OR, and it makes it a lot easier.
Just watching, studying cataract coach videos. That was fantastic. So this surgeon will certainly blossom into an accomplished cataract expert. It'll just take time. Cortex removal. Let's see the technique here. Looks pretty good.
And then
nice circumferential pulling.
Yeah, kind of the hurricane
technique. A little bit of radial tugging. Looking good.
Radial tugging, what he called it, yeah.
Now be careful. If you're the surgeon who sent this video and we kept you anonymous, they thank you for the praise because you've done a lot of things well here, but just understand the lack of experience with doing so few cases means that you're very early in the learning curve.
Yeah.
And make sure you still are your own toughest critic. Strive to be better and better every case.
Trying to polish.
If this is your case number 8, you can be a world-class surgeon. Just give it 1,000 cases. Be patient enough. Here comes the IOL. Let's see what we got here. Delivering it very nicely.
So try to keep the eye in primary, kind of
lens opening up very well in the capsular bag.
A little bit.
And wow, time to finish up the case.
Push it in the back.
Fantastic case. Great job. You're well on your way to becoming a cataract expert, even though you've just done 8 cases. Maybe with this, you're already at 10 or 20. But keep up the good work and be your own toughest critic. Accept the praise, but don't kind of rest on it.
The funny thing is the way kind of our cataract cases fall in our rotations, and because of COVID hitting and all, I missed some cataracts, and so I haven't actually done, I only did 7 more cataracts since that case. So I only have 15 in total, which is like really low. And that was number 8, I think, 8 or 9. But so I've only done 15, and then I'll have all my cases more toward the end of 3rd year, just the way my schedule fell. So I'll still get a lot, hopefully over 200 cataracts in residency. But anyways, just the way it's fallen, it's been kind of a big break in between doing those as a 2nd year resident, and then, you know, the next time I'll operate, which will be, I guess, in the next couple months. But anyways, so that was me doing phaco case number 8 or 9, I think it was 8, on my 2nd day of doing surgery, doing any intraocular surgery. We don't do any stepwise approach of like doing a wound and then doing the rhexis. It's all there. That was, you know, 4 or 5 cases a day from day 1, and so that was day 2. I had like 4 cases that day. And then that was case number 8 or something. So anyways, I hope you guys liked the video. That is me doing surgery. I don't know what that's worth to anyone, but anyways, I thought I'd review it, and it was kind of cool to be featured on his YouTube channel, because I really respect his opinion on things, because he seems to be an excellent surgeon. And so nice to have him review my video, and then I'll probably send him more later, you know, to get more tips and feedback, just because, you know, it's so helpful to have that feedback. So anyways, if you guys liked the video, leave a like on it, subscribe to the channel. I'm Zach with Dr. Eyeball MD. I'll see you guys in the next video.